Hi everybody, I'm Rachel Miller, and today I'll be presenting my single system design project exploring the use of cognitive behavioral therapy delivered in a structural group setting to reduce chronic depressive symptoms using an ABA design. For completing my client's intake assessment, she was a 24-year-old Caucasian female who recently initiated services at Pathways. We did the biopsychosocial intake form and conducted an open-ended interview. She completed the PHQ-9 and the GAD-7 scales to quantify her depressive and anxiety symptoms. Confidentiality was ensured throughout, and she was willing to participate in my project, so I really appreciate all the help that she gave me. So my client had some pretty complex trauma history. She did have childhood sexual abuse in an unstable home environment. She also recently found out through her parents, well, her mother and her stepfather, that she suffered a traumatic brain injury at the age of 5. So all throughout school, she struggled and had a IEP, but never really realized the reasoning behind that. So they do believe that the traumatic brain injury caused a lot of her learning disability and cognitive impairments. So that was kind of difficult to go through with her. She does currently live with her family, so her mother, stepfather, older brother, and older sister. She recently is employed. She recently was employed by the USPS, but she's currently debating on quitting due to just it's overwhelming for her to the point where she is exhausted after work every day just interacting with people due to her anxiety and her depression. So that was challenging to work through. During my client's assessment, I observed that she had a unkempt appearance. She had some attention difficulties and occasional unusual behaviors. But despite this, she did demonstrate clear strengths and demonstration of determination and being a good friend, good daughter. She feels that she is a hard worker, even though she does not like her job currently. And though she often reframes her strengths negatively, she did discuss that she is very artistic. We did look at some of her artwork, and she wants to be able to further her education in that area, and she wants to eventually do like web design and maybe paint murals for businesses and stuff. But she did have challenges of, she would say, well, I'm very artistic, but I don't think that's always a good thing. So that was kind of challenging. I prioritized depression mainly because this was her main issue and affecting her daily functioning. So her lack of energy and motivation significantly impacted her relationships with friends, family members, and even her professional performance. Additionally, her anxiety symptoms seem to intensify when her depressive symptoms become worse. So my reasoning is that we would first stabilize the depressive symptoms, and then she would be able to have a greater capacity to address her anxiety symptoms in future sessions. The overall target goal is to reduce the depressive symptoms by helping her develop 4 healthy coping strategies, increase engagement with friends and loved ones, and improve her overall mood and daily functioning. The intention is not to just symptom reduction, but improvement in quality of life and participation in meaningful activities on a daily basis. The primary intervention selected is cognitive behavioral therapy. CBT focuses on identifying and restructuring negative thought patterns while also increasing engagement in positive behaviors through behavioral activation. Research strongly supports CBT as an effective treatment for depression and anxiety, including studies by Curtis and colleagues and NACO and colleagues, which demonstrate its effectiveness in reducing symptoms and improving daily functioning. So my client's going to attend a group called Therapeutic Rehabilitation, and that is through Pathways Monday through Friday or Monday through Thursday from 9 a.m. to 12 p.m. So the group is a therapist-led group. It follows a structured curriculum that covers coping skills, daily living skills, communication, and anger management. And I think this would be a very beneficial group for her, especially with the cognitive impairment. The group will provide both skill development and a safe environment for her, where she can be active socially and engage with others. And while challenges may arise in the group setting, the therapist will support all the clients and make sure that everything's handled ethically and safely. To measure the progress, I tracked attendance and engagement in several ways. The client attends group therapy daily, Monday through Thursday in an outpatient office setting. A community support associate or CSA works with the client weekly in community settings to practice the coping skills that she's learned in real life situations. And additionally, a social worker will meet with the client bi-weekly to assess her progress. And then the primary measurable outcome is the weekly depression symptom tracker that I created. It's kind of along the lines of the PHQ-9 and the GAD-7. And then it also includes 6 self-report questions rated on a scale from 0 to 4, with 0 meaning not at all and 4 meaning extremely. And these questions assess like the sadness, the loss of interest, fatigue, negative self-thoughts, hopelessness, avoidance behaviors, and the depressive symptoms that she faces. And then the scores range from 0 to 24, with higher scores indicating more severe depression. And then this tool allows for consistent weekly monitoring to make sure that she is progressing positively instead of degressing. And this is my weekly tracker, the ABA single system design. I used the ABA single system design with the first phase, baseline measured depression severity before the intervention. And then the second phase introduced the CBT and group participation. And then the final withdrawal phase reduced structured intervention to evaluate whether she had improvements with her depressive symptoms and if they were maintained or if they got worse. The design allows observation whether the challenges and depressive symptoms correspond directly to the intervention. I made sure that cultural and identity factors were considered when doing this assessment. Even though we live in a rural community and diversity is very limited, I still feel that it's important to address that, including like potential stigma surrounding mental health and family dynamics, just understanding where she came from and what she's been through. So ethical considerations included maintaining confidentiality with HIPAA guidelines, obtaining informed consent from her, and carefully monitoring her symptoms during the assessment. Ongoing assessment ensured that the client's safety remained a top priority. My study does have a lot of limitations. Firstly, it's only 10 weeks long. That limits our ability to determine long-term effectiveness. Secondly, the withdrawal phase might raise ethical concerns because we're removing a structured treatment plan and it could worsen symptoms. And then thirdly, a self-report measure like the PHQ-9 and the GAD-7 may have biases. External stressors such as with her family. She has some difficulties with her family, especially her mother, could cause some problems. And finally, the single system design with one participant is kind of challenging because it's not generalized broadly. So in the future, this should be extended beyond a 10-week tracker. and it needs to extend the intervention duration, maintain structured support, and continue integrating community and social work collaboration with the client. These strategies aim to sustain symptom reduction and improve long-term functioning. So I think that would be probably the most beneficial thing to do in the future if I was to use this same single system design.